Hello, everyone. This is Christiana Best, and I am here with Dr. Keisha Moore, who is a senior researcher at the Thurgood Marshall Institute. Thank you for being here with us today, Dr. Moore.
Thank you so much for inviting me.
Yes. So part of the work that you do is looking at the inequities related to COVID-19 as well as vaccine distribution. And before we get started, I just want to share with the audience that Black and Indigenous people of color and other people of color have been disproportionately affected by COVID-19, not due to behavior as much as it is due to historical racism, social determinants of health, and previously been prevented from having fair opportunities in employment, emotional, and physical health. Studies have shown that race, ethnicity, and socioeconomic status, access to healthcare, and exposure to the virus due to occupation, such as frontline staff as well as essential workers, contribute to poor outcomes for people of color due to the virus. In addition to that, we know that while the coronavirus cases in the United States, the majority of them occur among white people who represent 60% of the US population, proportionately, people of color have a higher risk of testing positive for the virus, being hospitalized, and dying from the virus than their white counterparts. So these are some facts that we know about that's occurring at this point. And before I continue, I just wanted to share that the Thurgood Marshall Institute is a multidisciplinary center within the NAACP Legal Defense Fund. Launched in 2015, the Institute complements the NAACP LDF's litigation strength and brings additional critical knowledge to the fight for racial justice, including research and targeted advocacy campaign. As we get started, my first question to you, Dr. Moore, is can you share with the audience some of the work that you and the Thurgood Marshall Institute, which I will be calling TMI as we proceed, have been doing as it relates to COVID-19 and the vaccine?
Yes, thank you so much for giving me this opportunity to just highlight some of the fabulous work that's been coming out of LDF more broadly. It focused around litigation and policy work on these issues, and TMI, which is the branch of LDF that's been focused on research and public education. And so one of the first pieces of work that I got to do early on in my career at TMI was to publish an article on structural racism as a public health crisis. It was the beginning of the pandemic, and we were observing all of those racial disparities in the COVID outcomes that you listed at the height of it. And at the time, it was kind of leading people to think, well, what's wrong with these people of color, right? Like maybe there's something biologically going on here, or some kind of behaviors that they're doing that are culturally inappropriate and that would make them more susceptible to the illness. And so we were very adamant that we needed to insert research into the debate and to help educate the larger population to understand that the racial disparities that you're seeing are actually the consequence of structural racism, not individual barriers. So individual behaviors. So that was one of the first pieces of work that I got to publish through TMI. In addition to that, we quickly moved on to publish a piece on COVID and jails and trying to help our community understand why the best source of protection for us as a larger community is to decarcerate and to move people, out of jails. The jails were a prominent vector of infection, and there was research that had been reported from the ACLU that at that time we had estimated that 100,000 Americans would die from COVID, and the research suggested that that was an underestimate because if we didn't address what was going on in jails, it would double those numbers to 200,000. which at the time was alarming and seemed like the sky was falling. Like, how could we have 200,000 people dying from this? And at the time, we just felt like we definitely have to help people understand why decarceration is the way to preserve public health. And after that, we quickly went into publishing some work around education equity in the pandemic, that there was a lot of concern around, learning loss that happened from shuttering the schools. There was a big debate around, should we allow schools to be open in person or not? And TMI does national research, so we study states all over the country, and LDF has a long history of doing litigation and advocacy while across the nation, but really targeting key areas of racial disparity in the South. And that was a place where we had already had very intense levels of COVID transmission, and there was a very strong political climate against remote schooling. And so we needed to intersperse science into this discussion and help people to understand that equity has to always be a factor and can't just be something that is on the sidelines to, after we get back to quote unquote normal. So we published a report, Equity for All, that was focused on how to pay attention to the health and economic impacts of the pandemic, which are not equitably distributed, as well as how to pay attention to the trauma that students and faculty have been experiencing as a result of the pandemic, as a result of the public witnessing of the murder of George Floyd and all of the events that were going on. It was very traumatic. And so we said, when you reopen schools, you have to be prepared to deal not just with health safety, but with psychological safety and to deal with trauma, because we know that interferes with learning. And we have to make sure that if trauma isn't addressed, that students behaving in particular ways that are manifestations of trauma don't get treated to harsh discipline policies. And so, we really wanted to get that message out and get it out early so that schools and advocates could prepare for the best year for opening schools in the 2021 school year. And at that time, a number of parents were concerned about, if I do have choices, how do I decide what's best for my child? So we produced a podcast that allowed parents to submit questions, and they were able to speak with a leading medical expert and educational litigation expert from LDF, as well as to speak with a psychologist or a school psychologist, and just really field the questions that parents were asking as they tried to make decisions that were appropriate for their children. And in addition to that, we also did the first release of this Principles of Equitable School Openings. And this was a combination, and it showed how well TMI fits within the overall LDF architecture, because it was produced by a combination of the research team, with the policy team, with the school litigation team. And we were able to produce a concise document targeted towards school administrators and advocates to really lay out, this is what you need to pay attention to in order to have a reopening that is racially equitable and safe for all. And so we actually have a part 2 version of that coming out. It should be released in the next week or so. And then the last thing that I had the privilege of working on over the summer was this, or in the spring, we did the COVID vaccine equity blog series. And that was something that we were talking about in our first conversation of how we met. And it was, for me, very exciting work to be able to publish kind of quick turnaround research to let people know, we already know there is this racial inequity in COVID outcomes. Now, how can we make sure that the vaccine doesn't, magnify or perpetuate that inequity? And so that's what that blog series was about. So in just a short period of time, I've been at TMI for about 2 years almost, and most of that time has been focused on what our world is focused on right now, which is COVID and how it affects all these different parts of our world and our lives. And I think that is what makes, for me as a researcher, this such a valuable position, to be able to bring research to bear in really tangible ways around the issues that are pressing for our community at this time.
Great. Well, thank you. Thank you. As you were talking, I was thinking about the work that you've been doing with communities and state representatives to spotlight the disproportionality and disparity of COVID-19 vaccine in Black communities and communities of color throughout the United States. Can you tell us how the virus impacted community of colors in 2020 and what is happening today?
Definitely. So, as you were mentioning at the top of the podcast, in 2020, the virus had these very large, very quickly identifiable disparate outcomes around race. And, in the beginning, we could see that although Black people are only 13% of the population, we were 24% of all COVID cases early on for all of the states that were presenting data by race, and many states weren't. And so we needed to do advocacy just to get that. And we also know that mostly Black communities were 8 out of the nation's top 20 counties with the highest rates of COVID. And so it was devastating in our community, and we wanted to do our best to draw attention to that so that we could intervene and pull those numbers down, because we know it's not a result of biology or physiology, it's a result of sociology, of how our society is organized. And so some of the things that I highlighted in our report on structural racism as a public health crisis are the things you identified at the top of the hour. The impact of segregation, right? Black people remain the most heavily segregated population in this country and have always been. And that's racial segregation combined with economic inequality creates this bubble of magnified risk. And so it makes more Black people more vulnerable to diseases like COVID. And you combine, the Black economic vulnerability in that many Black people were employed in what was called essential worker service fields, which put them in contact with, in highly exposed situations where they could be contract COVID. And they did not have the ability to work from home as many other people may have, those who were fortunate enough to be able to keep their jobs during the transition. Black workers make up about 12% of all the workforce, but they're 17% of frontline workers. And they're 20% of all childcare and social service workers. And so a lot of the essential jobs that put people in direct contact with other people are heavily occupied by Black people. They're also 18% of the transportation jobs, the trucking, warehouse, and postal service. And so we have this situation where Black people are more likely to still be working during the pandemic, but they're less likely to have access to healthcare, to have paid sick leave, to have insurance. And so those things make it more likely that, one, if they are sick, they're probably going to have to try to work so that they can, continue to feed their families and support their jobs. And two, if they do have to stay out of work, they're going to lose income as a direct result of that. So only 58% of Black workers have paid sick days, as compared to 66% of white workers at the time. And so we have this situation where there's a lot of economic vulnerability that's combined with racial vulnerability that is in the same community, right? Because there are living together. We also want to add on to that this thing about transportation. And so just having to take public transportation, especially early on in the pandemic, increased your vulnerability to contracting COVID exponentially. And so there was some early research that was done that showed that when you controlled for transportation, it actually decreased the racial gap in terms of COVID. But it didn't decrease it for Black people. So it accounted for a lot of the racial divisions in terms of COVID. Transportation accounted for a lot of that, and Black workers are more likely to use public transportation than other workers. And then you add on to that housing, the fact that communities of color, Black, Latinx, and Asian are more likely to live in multi-generational households. They're more likely to have density in their households. All of the things that, according to the CDC, aren't great things that put us at risk, right? And this idea of, well, people should quarantine and social distance. Well, how do you quarantine when, you have a number of people living in a very small space? So those are the issues that that contributed to this kind of intensified racial disparity in the beginning. So we identified that, and then 18 months later, I would say, I'd like to say that was over and it's done, but it's not. So the pandemic is not done. As you said, this country, the entire country now is grappling with a new and more infectious version of the COVID variant than the one we were, at the beginning of the pandemic. And we still see these racial and economic disparities. So the US as a whole has had an increase in COVID cases. The 2-week average as of August 5th, there was a 135% increase in the cases. And the trend is even more pronounced in southern states, which again is where a lot of LDF focuses on. And so we monitor those states very closely. So in South Carolina, there was a 275% increase in COVID. In Arkansas, 80% increase, 143% increase in Florida, and 161% increase in Mississippi. And this is in 2 weeks at the beginning of August. And so the increases have, just been going on. And so we are still in a time where this is a very dangerous virus and it is spreading very rapidly. And it demonstrates kind of how quickly public health risks can emerge. So we kind of thought, oh, we had a handle on it. We really didn't, because we don't have enough people in not just this country, but in the world vaccinated. And so without enough people vaccinated, all of these variants are going to kind of continue to go around and get stronger and effectively make our lives worse or make it more difficult to control it. And there still remains a racial vulnerability to that. So as the virus itself spreads, Black and Latinx people remain more vulnerable because they're still in the jobs that put them in contact with more people, and still in concentrated housing and still relying on public transportation. So all of the things that made us vulnerable at the beginning of the pandemic remain true. The good news is that there has been a recent increase in Black and Latinx people getting vaccinated. And so the racial disparities in vaccinations has begun to shrink over time. So we have Latinx people are about 26% of recent vaccinations, and they're 17% of the population, right? And so we see this kind of growing emphasis on vaccinations. And again, Black people are about 15% of the recent vaccinations and 13% of the population. So Black and Latinx communities are doing what they can to protect themselves as much as possible, which is to get vaccinated and to ensure that their lives are preserved and they're able to live and work in the conditions that we are currently in. So all of that research that I just shared come from the Kaiser Family Foundation. They have a COVID data dashboard and a COVID-19 vaccine monitoring dashboard. And those are great resources for people who want to just check and see how we're doing and how it's changing over time. But the main point is that Black and Latinx people have received smaller shares of the vaccination than their percentage of COVID cases and then their percentage of the total population. So for the states that reveal cases broken down by race and that show vaccinations broken down by race, which is not the entire 50 states of the United States. Right now it's just 42. But for those states, there's still a under representation of Black and Latinx residents in terms of access to, in terms of getting vaccinated. And there's an over-representation of white residents in terms of vaccinations. And so that pattern does remain high, although it is starting to shrink. So for at the beginning, I would say, and according to September 7th, that's where I have the most recent data, white people who have received at least one dose of the COVID vaccination is about 1.2 times higher than the rate of Black people and 1.1 times higher than the rate of Hispanic people. So as of September 7th, about 52% of white people have received at least one dose of the vaccine. For COVID, about 43% of Black people have received at least one dose, and about 48% of Hispanic people have received at least one dose. So it is encouraging to see the gap shrinking, but it is still too large of a gap, and recognizing the fact that Black and Latinx people are overrepresented in COVID cases and overrepresented in deaths. To me, to get parity, it would have to be our rates of vaccinations are as high as our rates of exposure to hospitalizations and death. And that's what true vaccine equity looks like. So we haven't reached that point at all yet.
Wow, well, thank you. You have shared a great deal of information. As a matter of fact, you've shared information that on a question that I had related to vaccine distribution. And so I am going to pivot and try to ask you a question. So do we know, I mean, structural racism is a significant component, I'm sure, but do we know why the vaccine distribution issue is so low for Black and Brown communities?
Yes, so it is a complicated issue and there are many ways to approach it. But what I would like to put as our number one priority is access. There were a few states or a few localities at the beginning of vaccine distribution that identified equity as a core part of how their vaccines were going to be distributed. And we do know in the places that used equity, they had much better outcomes in terms of racial disparities in vaccines. However, because of the perception that Black and Latinx people are going to not want vaccines, that perception actually led some decision makers, some policymakers to think, well, we only have a few vaccines, so let's not give them in those areas. Let's give them to places where we know people, quote unquote, want them. And so I'd like to give you an example of what happened in Alabama and how that shows, how dangerous the perception of vaccine hesitancy can be when it's used against giving Black people access. And so in Mobile County, Alabama, out of the 18 sites, vaccination sites that were listed on the Alabama Public Health Department website, 14 out of those 18 sites were located in the whiter half neighborhoods in the county. So predominantly white communities are getting an overwhelming share of the access to the vaccines, like very early on. And then there was, in that same month, a health clinic, it was Alabama Regional Medical Services, and they primarily serve a low-income Black neighborhood. So a low-income Black neighborhood that had very high rates of COVID infection, high rates of hospitalization, high rates of death. And they had not at the time received one dose of the COVID-19 vaccine. And so, all of the public health, administrators keep saying, of course, equity should be central to how we approach this. And the communities that have high rates of transmission, those should be our top priorities in terms of getting, early access to vaccines there. And when asked about, why this particular community didn't get any, and these other, more white and affluent communities got so many, a local commissioner in Jefferson County said, well, the state officials told her that they're not distributing vaccines to majority Black neighborhoods because they expect that people would be hesitant to take them. So that's a great example about how the perception of, there's something about those people that's, not going to lead them to make decisions that prioritize their health is used to justify behavior that actually denies access to those people for critical health saving measures. And so access remains important. It always matters. And there's so many ways in which we can prioritize access that we have not done. And so until you get to 100% checking off all of those access barriers, I don't entertain conversations about hesitancy because we don't know how many people don't want it when we haven't actually offered it to them. And so the differences in vaccine uptake, I believe in our research suggests that are much more about vaccine availability than they are about vaccine hesitancy. Now, a lot of when I was doing, our research at TMI on following this, it was early on in the vaccine distribution. And so we didn't have enough vaccinations to send to everybody in need, and we were doing this priority. So access was even more critical then. It would still be really interesting and important. I haven't had the opportunity to return to those places and look at issues of distribution and equity, but my spidey sense would tell me that access remains a really important factor in that population.
Okay, great. So this whole issue of vaccine hesitancy is being used against the same people who may even have reasons to be hesitant about it based on historical atrocities, right? That is incredible. It's really incredible. Wow.
Yeah, it's another example of our blame the victim response. And, because we do have a history of racism in healthcare, right? And we don't have to go back to the Tuskegee experiment in order to talk about that history. Right. And we do have, examples where Black people are less likely to get access to pain medication and, all kinds of health disparities that exist by race that are perpetuated within the medical system. And so to treat people who have been harmed by the medical system based on their race as if they're crazy for thinking that that medical system does not hold their best interests at heart doesn't really make a lot of sense. But it's been even more perverted to be used against them to deny people who do want these life-saving resources, these vaccines, the ability to get them.
Right, right. Thank you for sharing that. So earlier you talked about states that have these equity committees. What can states do to address high rates of infection, hospitalization, and death in communities of color, especially in light of increasing infection rates related to the Delta variant?
Yeah, that is such a critical question. What I would say is that we know from the equity task force that have been initiated that targeted intervention matters. So Chicago was one of the first places to do this, equity distribution model and how it distributed vaccines. And it started out the gate in January with their campaign, Protect Chicago Plus. And the mayor said, equity is going to be central to our approach, that the goal is to make sure that the communities who bore the heaviest burden of COVID-19 get first access to the vaccine. And when we do that, that protects the health and well-being of all of us, of the entire city. And that's true. And what we saw in that pilot program is that the communities that were targeted in this program did have above average vaccination rates for the city. So they targeted these communities and it worked. These communities had higher vaccination rates. The challenge was some of the communities who should have been on that list weren't on that list, right? Communities that had even higher rates of COVID hospitalizations and deaths had not made that list. And I've seen that pattern in a number of the states that I studied and wrote about in the blog series, that we have a veneer of equity. And we say, equity matters, but then when you look at the criteria and you look at what are the places that are actually included and what are the places that aren't included, you recognize it's equity plus, right? And I don't know what that plus is. There are lots of things that go into policymakers' decisions that aren't just about the data. But as a scientist, I'm just about the data. So if you say we're going to prioritize the places that have the highest rates, those are the places that I expect to see prioritized. And that didn't play out in Chicago. So some of those places had the highest rates, but some did not. And secondly, what we saw is that some of those very highly vulnerable places that were included in the target, their vaccination rates increased, but not as high as the citywide average. And so that tells me that not only including highly vulnerable people in targeted interventions, but that they may also need more targeted interventions, right? That we need to do something differently in this inclusion that may not be necessary for some of the other places. So what are some of those things that I think we can do? And when we have done them, we've seen evidence that it actually matters in terms of equity in vaccines. What we see is prioritizing the expansion of vaccination sites within communities of color makes a big difference, so that people don't have to leave their neighborhood, they don't have to get on the bus in order to get vaccinated. And when I say vaccination sites, I'm not just referring to your local hospitals, and because a lot of Black and Latinx residents live in communities that they used to be trauma deserts, they're now vaccine deserts, right? That there is not a a health infrastructure in these communities, because these are the places where we have closed down the hospitals, we have closed down the clinics. There's been a long history of disinvestment in the health infrastructure in the community. So then if you want to rely on health infrastructure to disseminate resources, it is of course going to be unequitable. And so when we have vaccination sites, we have to think outside of the box in terms of, existing health infrastructure, and have pop-up vaccination sites, or mobile vaccination sites. There's some places where they went to public housing units and vaccinated people there, right? That makes sense. Go to where people are, especially people who have the most limited resources. Go to those communities to remove all of the barriers. The other thing that we know matters is collaborating with community-based organizations, organizations that are in the community, that are trusted by the community, that have been a part of and invested in the community for years, decades, right? Like nobody is going to be trusting of, a new person coming to town. I don't know you. I don't know or believe that you have my best interest at heart. Right. And so when we collaborate with those community-based institutions, we know these are the kinds of places that we could use, that people would feel comfortable coming to. We can use our community partners to teach us like how to organize the system so that people have access to it. Maybe it doesn't make sense for us to have registration online, right? Especially given the broadband inequalities that exist. And so people who are grounded in these community-based institutions already know this knowledge and already know what's the best way to deliver resources to the communities that they serve. The other thing is that these community partners are trusted vehicles of information and can have conversations with people about what are their concerns around the vaccine, around the virus, around the science behind it. And it is so important that these conversations are conversations, not this one-way disrespectful mode of communication, like, you shouldn't even ask any questions. I know everything, you don't know anything. Everybody wants to feel included in the decision-making about their health, and everybody deserves to be included. And that means arming people with the proper information. And our communities have been specifically targeted for disinformation, in social media around this. And so that makes it even more critical that the people who we already know who you are, you're not a bot on, Twitter, you're a real person that I've been interacting with, to have that person have a conversation with me and treat me with respect and answer my questions and respond to me and leave that decision-making up to me. That is absolutely critical. The other thing when we're talking about addressing racial disparities is we need to do specific targeting of unhoused people and people who are incarcerated. Because of systemic racism, Black people are disproportionately shown in both of those communities, people who are incarcerated as well as people who are unhoused. And so if we rely on, assuming that our residents are people who, can get on a bus and come, or, who have an address that they live in, those kinds of things will leave out significant parts of the population that, need to be included. And we need to not only include them, but specifically prioritize them, because those are the populations that are even the most vulnerable, even within the Black community, of COVID infections and hospitalizations and death. And the last thing that I would add is for people who are employed, we need to remove the barriers to vaccination that low wage employment creates. Right, so very few Black people very few low-wage workers have the opportunity to take time off to get vaccinated. When I got vaccinated, that was 4 hours of my day. I had to drive there, stand in line for whatever, and then come back. I had to do that 2 times. And I was really nervous about how I'd be feeling afterwards. And, the doctor's like, oh, we'll go and lay down. And, that's a very privileged opportunity. Who can come just go and lay down after being away from work for 4 hours? So if we set up, 24/7 vaccination hubs that would allow people to come at their, off work hours, if we had walk-in vaccination clinics where you don't have to schedule an appointment and it can be more flexible with your work schedule, those are all kinds of things that we can do to remove every hurdle that exists in front of people who may want to be vaccinated or are seriously considering it, but there are just so many barriers in between them and the vaccine that, they just don't make that choice.
That is so true. I just remember an incident in New York City where there was a vaccine hub at a local drugstore in a Black and Latinx neighborhood. But in order for you to go and get the vaccine, you had to get online and register. And many of the people there were elderly, Black and Latinx, and didn't have access to a computer. And if they did, they probably didn't know how to do it, because that system is not easy to navigate, because I tried it.
Not at all.
It's not easy to navigate. And so, but however, white adults, some of which were elderly, had their grandchildren get online and register them for the vaccine in the Black neighborhood, and they would come with their cars, some of them in limousines, and go get their vaccine. And the pharmacist said, wait a minute, he didn't recognize none of these people that were coming in. He knew the regular people, and these folks were not the regular folks, but he couldn't do anything about it because those who registered got the vaccine. So it's just so amazing about this thing about racial inequities.
Yes, that has its own term for it. It's called vaccine tourism.
Okay, all right, there you go. It was amazing. I'm like, they're coming from Long Island, the suburbs of Long Island, to a neighborhood they wouldn't even live in, to get something that meant taking away from the folks who were living there. This is just, it tells you so much about how the world is organized and how this country is organized, right?
Right, you're right. And this world, because we've seen vaccine tourism internationally.
Right.
We've seen vaccine tourism on indigenous reservations, and we've seen vaccine tourism in Black and Latinx neighborhoods. And so people who have means have been able to be the first in line, in all kinds of ways to protect their position. And that is a privilege. And it is, as you said, taking away from people who don't have the same resources and have even more vulnerability because,
right.
They're right. in the kinds of communities where it's raging. Yeah. So there is so much that we can do to promote equity, and we should definitely be talking about that before we blame people for not being vaccinated.
Absolutely. Wow. So that takes me to a more macro level. And I'm wondering, how can we get the federal government and to some extent local officials, because sometimes when the federal government give access, the local government is the one who really have control over it. How can we get these politicians and policymakers to address social structural racism in a meaningful way that would equalize or bring equity to the distribution of COVID-19? And I'm thinking that this is probably a really good lesson for those that are privileged to see and to understand how structural racism works, even in a pandemic, the amazing inequities that are occurring. Yeah, so I may have lost my question there, but.
No, I think it's the right question we should all be asking about, what can we do And as you said, what we are seeing in COVID-19 in the outcomes of the pandemic is just an X-ray of what exists within our society every day, right? That this is structural racism and this is how it manifests itself. And the beauty of that is now that maybe some of us can see it more clearly, then in working to address that, we can address systemic racism, because you can't have, this structure of structural inequality and not have it show up in your education system and in your economy and in your health care system. And so picking any one piece of that thread requires that as you start to untangle it, you address these structural issues. And so COVID is a beautiful opportunity for us collectively to do that and to recognize that the health, literal health of our society requires that we promote equity and justice. Like it just does, and it's no way else around it. And, LDF has been committed to working on, addressing racial injustice for 80 plus years. And the strategies that we use are the strategies that we believe, have the opportunity to make the most difference. And that is, we fight on all fronts at all times, because that is what it requires. So, we communicate our message and we put active pressure on policymakers and decision makers. And sometimes that comes through the courts, sometimes that comes through litigation, sometimes that comes through public policy at the federal level, at the state level, at the local level. Sometimes that comes through organizing, educating, and mobilizing a public to join with us in these fights. But all that we can do to communicate the problem clearly, to clearly understand that our problem is not what's wrong with those Black people, why won't they get vaccinated? Our problem is we have a society that is built on structural racism, and that puts people's lives in jeopardy. It means that Black and Latinx people and low income people and people who exist who are marginalized in our society, those are the people who are going to be the first and the most, but not the only people to, die from these pandemics. And so the way that we preserve our whole society is by strengthening the places that are most vulnerable and creating true systems of health. And that's what the system of public health is actually about, right? Like that's why sanitation is, such a critical part of promoting health and well-being in society. Like it's not just go to the doctor, it's how do we change the environment? How do we change the structure so that we can all live and thrive? And so, I appreciate having the opportunity to write and to publish and to come and speak with you, Dr. Bess, and your audience about this, because I think it is a beautiful window for us to really begin grappling more seriously with these issues that we've been talking about, some of us, for a really long time.
Well, thank you so much for that, Dr. Moore. The work that you're doing at the Thurgood Marshall Institute is really important work. It certainly amplifies the voices of the unheard. And we are really appreciate to have an institution that is in the forefront, one of many institutions in the forefront, bringing these issues for us to grapple with, but also fighting on our behalf. In conclusion, I usually ask my guests what if any last message you have for the audience around the issue of equity and COVID-19.
I think I gave my last message and my last answer, that it is that structural racism kills. It does. And so these racial disparities that we are seeing are not the result of biological or cultural deficiencies. They are the reflection of deeply embedded structural dynamics that create racialized health disparities. And COVID is just one manifestation of that. So from the cradle to, the grave, there are a host of outcomes that are different by race, and that is not coincidence. And we now have an opportunity to address these institutional racial disparities. And if we do that well, we will not only be able to, manage this pandemic that we're in, but we're going to make ourselves a better society in the future. So yeah, that would be my closing thought.
Well, thank you very much. I think for me, what I heard is that structural racism kills, and not just the oppressed, but everyone eventually. It's only a matter of time. And this is an opportunity for us to stay clear-eyed and see the issue, see the problem, and address it. So, because if we address it, everyone will gain from it.
Absolutely. Absolutely. We are a community, and as Dr. Martin Luther King said, we will either learn to live together as brothers and sisters, or we will perish as fools. There is no other choice.
Perfect last words. Thank you so very much. And thank you to the Thurgood Marshall Institute for all the good work you're doing.